Warmly welcome everyone to the e-sfar. The theme of this session is a discussion on arterial blood pressure in the operating room. I'm grateful to the e-sfar and its organizing committee who have arranged this session. And it's a pleasure for me to welcome all speakers. Dr. Nguyen, Dr. A.JOOSTEN, Dr. Godet, and Professor Langlois. So the theme of this session is a discussion. We're going to discuss about the optimal blood pressure, how to process with hypotension during operating theater, and how to treat arterial hypotension and how to predict arterial hypotension. So let's move on to the first item with Dr. A.JOOSTEN.
Yes, so I'm the first speaker. I have to discuss what is the optimal blood pressure during surgery. As you can see, I have been at the Erasmus Hospital in Brussels, but now I work in Paul Brousse and Bicêtre Hospital in Paris. I have some conflicts of interest that I have to disclose, and they are mentioned in this slide. So hypertension during surgery is frequent, is common, and has multifactorial etiology, such as vasodilation due to anesthetic drugs, intravascular hypovolemia due to acute bleeding, low cardiac output due to bradycardia or low stroke volume. Mechanical ventilation can also cause hypertension and impairment in baroreflex regulation. We know that today we have a lot of large retrospective studies showing that there is a strong association between a low blood pressure during surgery and the incidence of postoperative complication, mainly acute kidney injury and acute myocardiac injury. We have a lot, as I said, of retrospective study, almost one each month in high impact factor journal, and I will discuss the latest one published in Anesthesia Analgesia last year, which included more than 368 patients undergoing non-cardiac surgery, and they defined intraoperative hypertension using different methods. The absolute maximum decrease below a specified MAP threshold, the total duration of hypertensive episode in orange, the total area under the threshold, and the time which average mean arterial pressure. What they showed is that whatever the definition, the primary outcome, which was the major adverse cardiovascular event, were significantly associated with a higher incidence of this event. What we also know is that as secondary outcome, you can see that there is a higher risk of acute myocardiac injury, acute kidney injury, and also 90-day mortality and sepsis when blood pressure go down. What we also know is that intraoperative hypertension can be defined using a threshold, so it's the severity of the hypertension, but also to the duration. For the severity, we know in this paper from the Cleveland Clinic, including more than 30,000 patients, that a MAP threshold below 65 is associated with an increased risk of acute kidney injury and myocardial injury. And when blood pressure is below 55, even a single minute of hypertension increases the risk. Here, a recent study including more than 23,000 non-cardiac surgery patients, and they defined hypertension as an absolute population risk for acute kidney injury and acute myocardiac injury, and this threshold was 65 for myocardiac injury and 60 for acute kidney injury. As said previously, we can also define it using a duration of hypertension, and in this paper from the same group, including more than 100,000 patients, there is an increased risk of 30-day mortality when mean arterial pressure is below 70 for more than 10 minutes. We also did a retrospective study on patients undergoing liver transplant surgery. And we showed that when patients spend less than 10% of hypertension during surgery, they have no acute kidney injury for more than 80% of them, and 15% of them will develop an acute kidney injury, but it's all the time an acute kidney injury, category 1, so a mild acute kidney injury. When patients spend between 10 and 40% of the surgical time in hypertension, they will have no acute kidney injury just for 36% of them, and acute kidney injury for 63% of them, 27 mild, 36 moderate to severe acute kidney injury. And when patients spend more than 40% of the total duration of the surgery in hypertension, it's the exact opposite of the first slide, the short duration. We have only 13% of patients who will not develop any acute kidney injury, and more than 85% will develop an acute kidney injury, 33% mild, and 53% moderate to severe. So all these studies were retrospective and can just assess an association, but of course there is no causal relation. But the question I have is, what is the optimal blood pressure? It means, can a threshold of mean arterial pressure improve patient outcome? Indeed, we just have 3 studies. The first one is this large multi-center study in China, including more than 600 elderly patients with chronic hypertension, and they were randomized to 3 groups of a map range between 65 to 79, a map range between 80 to 95, or above 96 to 110. The primary outcome was acute kidney injury stage 1 during the first week after surgery. And patients randomized in the group with a map between 80 and 95 had a lower incidence of postoperative acute kidney injury. So in elderly patients with chronic hypertension, a map between 80 to 95 seems to be beneficial for the kidney. This recent paper, including more than 400 patients at cardiovascular risk undergoing major non-cardiac surgery, were randomized to 2 map range. One is to maintain a mean arterial pressure above 75 versus above 60. The primary outcome was a composite endpoint, including acute myocardial injury during the first 3 days post-surgery and 30-day major adverse cardiovascular event and acute kidney injury. Unfortunately, this study did not show any difference between the 2 groups. And in the discussion, they said that we can move from a population-based threshold to a more individualized definition of hypertension. And we have one randomized controlled trial done by Futier and colleagues 4 years ago, including more than 290 high-risk patients in blood pressure, systolic blood pressure to be maintained within 10% of the baseline blood pressure of the patient using noradrenaline infusion from the induction until the end of the surgery, versus a group where the goal was to maintain a systolic blood pressure above 80 using ephedrine. The author showed that the individualized group had a lower incidence of organ dysfunction compared to the standard of care group. And therefore, today, the anesthesia community prone a lot this concept of personalized blood pressure management in the perioperative period. However, what is the good baseline preoperative blood pressure for the patient? This study showed 2 or 3 important messages. The first one is that pre-induction mean arterial pressure cannot be used as a surrogate for normal daytime mean arterial pressure, and that the lowest post-induction and intraoperative map are lower than the lowest nighttime mean arterial pressure in most patients. What they did is that they use a non-invasive blood pressure, continuous blood pressure monitoring, and they recorded blood pressure during the day before surgery. And they showed that 1/3 of the patient, they had a lower, the lowest mean arterial pressure was below 65, and 2/3 of them had the lowest, the lower nighttime mean arterial pressure was above 65, meaning that for this patient, probably to target a blood pressure of 65 can be too low during surgery. So we do have some systematic review, this one including more than 40 studies, and they showed that there is an increased risk of organ dysfunction if MAP is below 80 for more than 10 minutes, below 70 for 5 minutes, or below 60 to 65, whatever the duration. In this guidelines paper, the author recommend to maintain systolic arterial pressure with 3 numbers, so above 100, and mean arterial pressure above 60 to 70 to reduce postoperative complication. In this other guidelines paper for acute kidney injury in the perioperative period, the author recommend maintaining a minimum MAP pressure between 60 to 70 to prevent AKI, and for patients with chronic hypertension, probably to target a higher mean arterial pressure, probably higher than 70. Here in this we can say key opinion leader paper, the author said, okay, we have evidence that there is injury when mean arterial pressure is below 60 to 70, that cardiovascular and renal complications, of course, are associated with baseline risk factor, but hypertension is, of course, something that we can act on in. And finally, they recommend to keep mean arterial pressure above 65 during surgery. So to conclude, hypertension is common during surgery and associated with organ dysfunction. Hypertension, it's important to consider both the severity, but also the duration of hypertension. The population harm threshold is different than individual safe threshold. There is no, unfortunately, universal blood pressure target during surgery. Intraoperative population harm threshold seems to be between 60 to 70. For MAP, and there is no minimal duration at this level of mean arterial pressure, and probably we can recommend to keep mean arterial pressure above 65 for normotensive patient and probably higher for hypertensive patient. We have a paper showing that individualized blood pressure management may be beneficial for the patient, and we need more randomized controlled trial on this topic. In fact, we have 2 large randomized controlled trial, the first one from the Cleveland Clinic, including more than 6,000 patients randomized to a mean arterial pressure above 85 using norepinephrine or phenylephrine infusion, and during the first 3 days post-surgery using a target of systolic arterial pressure above 110 versus standard of care. And another one, pilot study by a team in Hamburg, when they tried to compare individualized blood pressure versus a standard of care group at 65. And they have just won a national grant, and they will perform a large randomized controlled trial including 2,500 patients randomized in an individualized blood pressure target versus 65 millimeter of mercury. So in the years to come, I think we'll have some additional answer on this topic. Thank you very much for your attention.
Thank you, Dr. A.JOOSTEN, for this lecture. So, any comment? I have a question because we treat blood pressure from the spectrum of hypotension, but how about hypertension, arterial hypertension?
Yeah, so if we have a lot of studies showing that there is a strong link between hypertension and adverse event, I want to say there is less evidence that hypertension can be deleterious for our patient. It's the same thing for blood pressure variability. It's less obvious that blood pressure variability during surgery has an impact on patient outcome. And that's it for me. Maybe another hypertension and complication.
Not much of an evidence for the hypertension, nor for blood pressure excursions. So blood pressure excursions is characterized by changes in mean arterial pressure between high values and low values. So what comes out is that it is hypertension. Now, if you look at it physiologically, it makes sense because physiologically hypertension is an exception, whether hypertension on exercise or other situations is, let's say, routine. But hypertension is not, except for nighttime hypertension. And when we look at data at nighttime hypertension, you as younger individuals probably have hours of diastolic pressures around 35, 40, and nothing happens to you. You have no means, you don't have anything. So the hypertension is not statistically associated with increase. I'm not saying you have to respect it, but statistically there's no signature of hypertension. My point is on wording. So the e-sfar guidelines that you showed was maintained. The first guideline that I know of is the 2014 ESA guideline on management of intra-op hemodynamics, and we said after long discussions we chose the term avoid hypertension, and we also chose this. So avoid, maintain and treat is not the same thing. So in my mind, we have here a representative from the Emmanuel Futier's team, but in my mind it is wrong to cite the Futier paper as targeted blood pressure. It is goal-directed therapy because they first optimize stroke volume, and once stroke volume is optimized, they individualize blood pressure. So in most of the citations, it is cited, this article, which is important, as an example of a treatment that improved outcome of hypertension. In my analysis, there is no evidence that treatment of arterial hypertension per se, I'm not talking about goal-directed therapy. So there's evidence that goal-directed therapy improves outcome, but there's no evidence in my analysis that specific targets of arterial blood pressure actually improve outcome. So this is still to be determined. I don't know if you, I think this message is important because otherwise people will cite the Futier paper saying, okay, Emmanuel Futier and his team, Pierre-Grégoire also co-signed this article, show that if you give norepinephrine and you maintain blood pressure at something, it's going to be better. I don't think this is the case. It should not be looked at simplistically.
No, but you have less arterial hypotension. But you have to optimize all determinant of blood pressure, and that's, I think, the main message. And I have a question, and after that we move on to the next item. There are thresholds specific to type of surgery, like in neurosurgery, or because most of the studies were performed in major abdominal surgery or in vascular surgery. But what about neurosurgery, cardiac surgery? We discussed.
So we don't have a paper on specific type of surgery, so there is still work to do on this.
Okay.
I cannot recommend any blood pressure target.
Okay, thank you.